ever felt that that moment, like you're climbing stairs and it just feels way harder than usual,
Yeah.
or, picking up something you normally lift easily and
Yeah, but
frustrating.
that feeling, that sense that your muscles just aren't quite firing on all cylinders.
Well, that kind of muscle weakness, that difficulty, that's really the core of what we're diving into today. Myopathies.
Exactly. Think of this as our focus session on myopathies. We've got a pretty comprehensive set of notes here, the kind you'd use for revision, maybe for the MSRA.
Right.
And we're going to really unpack them, pull out the absolute essentials. The aim is to give you a clear, structured overview, what they are, causes, diagnosis, but without getting totally lost in the weeds.
So maybe you're prepping for exams, or perhaps you're trying to understand a diagnosis someone mentioned, or maybe you're just curious about, well, how muscles can go wrong. This is for you.
Yeah, we want to make this genuinely useful, maybe even help it stick with a few memory aids along the way.
And these notes look pretty thorough: definition, causes, management, the whole lot.
They are. It's a good base. So our mission really is to give you that solid understanding of myopathies,
Yeah.
key concepts, how it all fits together.
Okay, let's get started then. Let's unpack the definition first. What exactly is a myopathy?
Right. So fundamentally, myopathies are disorders where the main issue is actually in the muscle tissue itself.
Not the nerves.
Not primarily, no.
Hmm.
The problem leads to muscle weakness, sometimes dysfunction, because the muscle fibers, the actual building blocks, aren't working right. Either their structure is off or their function is impaired somehow.
Ah, okay. So the signals might be getting the muscle okay, but the muscle itself can't respond properly.
Precisely. That's a really key distinction.
Yeah.
The nervous system itself, the neuromuscular junction, they're generally not the root cause here. The problem originates within the muscle.
And it covers quite a range of things.
Oh, definitely. It's a broad category. It includes things people might have heard of, like muscular dystrophies. Those are usually inherited.
Yep.
But it also includes other conditions that affect muscle tissue, which you might acquire later in life.
And they don't all look the same in terms of how they start, do they?
No, not at all. Some have a really slow, gradual onset. Maybe they're even there from birth, congenital myopathies. Others can come on much more quickly, acutely.
But spotting it early is important either way.
Absolutely crucial. Early recognition makes a huge difference for management.
Okay, this is where it starts to get really interesting. The causes. What actually leads to these problems?
Well, the causes, the etiology, are pretty varied. You
Yeah.
can broadly think about it in two main camps, genetic and acquired.
Genetic first.
Yeah, a lot of myopathies have a genetic root. Some kind of inherited abnormality basically messes up the muscle fibers. Maybe it affects the proteins they're built from, or some vital process inside the fiber, like a flaw in the blueprint, you could say.
Okay, that makes sense for the inherited ones. But what about the acquired types, the ones people develop?
Right, acquired myopathies. These can pop up for different reasons. Inflammation is when the muscles themselves get inflamed. Autoimmune conditions are another big one. That's where your own immune system mistakenly attacks the muscle tissue.
Right, the body attacking itself.
Exactly. Then you've got metabolic problems. Issues with how the body handles energy or chemicals can disrupt muscle function. Certain medications, unfortunately, can have muscle weakness as a side effect, too.
I've heard about that with statins sometimes.
That's a well-known example, yes. And also, infections can trigger myopathies, exposure to toxins. Even other underlying medical conditions can sometimes lead to muscle problems.
Can we break that down a bit more? Maybe some specific examples for inherited versus acquired.
Sure. So inherited, you've got the muscular dystrophies like Duchenne or Becker. Those are classic genetic examples. And also some inherited biochemical defects, problems with muscle energy metabolism.
Okay.
Then acquired, you've got the immunologically mediated ones like polymyositis or dermatomyositis. That's the immune system attacking muscle. Then there are non-inflammatory ones linked to things like thyroid problems or diabetes. And then toxic causes like too much alcohol, certain drugs, or even severe illness causing muscle wasting, which we call cachectic myopathy.
So lots of potential pathways. Okay, connecting the dots, risk factors. What makes someone more likely to get a myopathy?
Well, it really hinges on the specific type of myopathy. For the inherited ones, it's pretty straightforward.
Family history.
Exactly. If the genetic mutation runs in the family, the risk goes up. Simple as that.
And for the acquired ones, is it linked to those other conditions you mentioned?
Often, yes. Having certain pre-existing conditions definitely increases the risk for acquired myopathies. Things like autoimmune diseases, lupus, rheumatoid arthritis, or metabolic issues like thyroid disorders or diabetes.
Makes sense.
And, as we said, exposure to certain medications or toxins can also be a risk factor for some people.
Let's delve a bit deeper now into the pathophysiology. What's actually going wrong inside the muscle cells?
So the central theme, really, is damage or dysfunction of the muscle fibers themselves, those long cells that do the contracting.
Okay.
And when they're damaged, a few things happen. Obviously, their ability to contract is impaired. That's the weakness we see.
Right.
It can also mess up their metabolism, how they get energy. Often there's inflammation involved as the body reacts to the damage. And you can get actual structural changes, like muscle fibers breaking down in dystrophies.
So it's not just one single mechanism causing the weakness?
No, definitely not. The end result might look similar in muscle weakness, but how you get there varies a lot. In Duchenne dystrophy, there's a missing protein, dystrophin, making fibers fragile.
Okay.
In something like polymyositis, immune cells are directly attacking the fibers.
Sure.
So the underlying process, the cascade inside the muscle, it's different depending on the specific myopathy.
Right. That's important. So thinking diagnostically, if someone comes in with muscle weakness, it's not always a myopathy, is it? What else needs to be on the list? The differentials.
Oh, absolutely. That's a critical step. You got to rule out other things that can cause weakness. Top contenders would include Guillain-Barré syndrome that affects the peripheral nerves, usually comes on faster.
Okay.
Then you have conditions affecting the neuromuscular junction, where the nerve talks to the muscle, like Lambert-Eaton syndrome or myasthenia gravis. They often cause fatigable weakness.
Fatigable meaning it gets worse with use.
Exactly. Often improves with rest.
Mm-hmm.
Then there's cerebral palsy, spinal muscular atrophy affecting motor neurons, and even some nerve conditions like congenital hypomyelinating neuropathies.
So quite a few mimics. How do you start telling them apart? You mentioned the pattern of weakness earlier. Memory tip. Thinking neuro if certain features are prominent.
Yes, the pattern is key. A lot of those neurological conditions often start more distally, hands and feet maybe moving upwards. You might also see changes in reflexes, often reduced or absent reflexes.
Okay.
And maybe fasciculations, those little muscle twitches under the skin.
Yeah.
Sensory symptoms, too, like numbness or tingling, are much more common if it's primarily a nerve issue.
Whereas myopathies tend to be.
More proximal, affecting shoulders and hips first. And reflexes are often preserved, at least initially. Sensory symptoms are usually absent. That pattern difference is a big clue.
Got it. Okay, let's talk scale. How common are these conditions? What's the epidemiology look like?
It really varies hugely. Myopathy is such a broad term. Some specific types are quite rare. Others are, well, more common.
Any examples with numbers?
Yeah, sure.
Yeah.
Duchenne muscular dystrophy, for instance, is one of the more common genetic ones in kids. Affects maybe 1 in every 3,300 to 3,600 live male births.
Wow, okay.
Becker muscular dystrophy, which is related but milder, is less common, maybe around 24 cases per million people. Inclusion body myositis tends to affect older adults more. Congenital muscular dystrophies are maybe about half as common as Duchenne. So you see, it's quite a range.
Right, definitely a spectrum. Okay, let's get practical. What clinical features, what signs and symptoms would actually make you suspect a myopathy in someone?
The absolute hallmark is usually symmetrical muscle weakness.
Yeah.
And critically, it's typically proximal more than distal.
Hips and shoulders again. Mnemonic time. Proximal power problem. Think PPP.
Exactly. That proximal weakness translates into everyday difficulties. Things like trouble getting up from a chair without using their arms, difficulty climbing stairs, maybe struggling to lift things overhead like washing their hair.
Getting out of the bath.
That's another classic one, yeah. A low bath can be really challenging.
And if you did a standard neurological exam?
Usually, sensation would be perfectly normal. Reflexes, too, often normal, especially early on. And you generally don't see those fasciculations, those muscle twitches.
So it's really honing in on that pattern of weakness.
It is. Shoulder girdle, pelvic girdle weakness. Now, how it presents can vary. In babies, it might be decreased fetal movement noticed before birth. In adults, it could be a really slow, insidious onset of weakness.
Any other symptoms? Pain?
Muscle pain or myalgia can be a feature, particularly in the inflammatory types like polymyositis, but it's not universal.
What about things like fatigue?
General fatigue or malaise can be there. But the fatigability you see in myasthenia gravis, where strength fades rapidly with use, that's different. In most primary myopathies, the weakness is more constant, though it might fluctuate a bit in metabolic types.
So when taking the history, You're listening for that symmetrical proximal weakness without sensory loss.
That's the core story usually. Later on, you might see muscle wasting, atrophy, and reflexes might diminish, but those are often later signs.
Does the speed it comes on give clues?
It can, yes. A really rapid onset might point towards a toxic cause, maybe a drug reaction, or an acute inflammatory process. Slower onset is more typical for inherited or chronic conditions.
And understanding the impact is important too?
Definitely. Asking how it affects them. Can they brush their hair? That points to shoulder weakness. Are they tripping a lot? Maybe hip flexor weakness.
What about those metabolic myopathies? Any specific things to ask about?
Yes, for those you'd specifically ask about exercise. Do they get unusually fatigued, cramped, or sore during or after exercise? Have they ever noticed dark, tea-colored urine after intense activity? That could be myoglobinuria, muscle protein breakdown products in the urine.
Crucial history points then. Past medical history, family history, meds.
All vital. Any autoimmune conditions, thyroid problems, diabetes, any family members with muscle weakness, a detailed medication list, including over-the-counter stuff and supplements, any occupational exposures to toxins, all potentially relevant.
And on examination, beyond the proximal weakness.
Well, the symmetrical proximal weakness is the main event. Muscle tenderness is actually pretty rare in most myopathies. You might find a fever if it's an inflammatory cause. In babies with congenital forms, you might notice low muscle tone, hypotonia.
Associated signs.
Always look for associated signs. For instance, the specific skin rashes you see in dermatomyositis are a major clue. And always check the urine, especially if you suspect acute muscle breakdown, like an acute alcoholic myopathy. You need to rule out myoglobinuria because of the risk to the kidneys, acute tubular necrosis.
Okay, so you suspect a myopathy based on the history and exam. How do you confirm it? What investigations are key?
We usually start with blood tests. A really, really important one is creatine kinase, CK.
CK memory tip. CK for creaky muscles, maybe?
Whatever works. But yes, CK. It's an enzyme that leaks out of damaged muscle. In many myopathies, especially inflammatory ones or dystrophies, the CK levels can be sky high. We're talking 50, even 100 times the normal upper limit.
Wow, that's significant.
It is. Sometimes we look at CK isoenzymes too to help pinpoint the source. Beyond CK, we check kidney function vital if there's muscle breakdown, electrolytes like calcium and magnesium, a full blood count, inflammatory markers like ESR or CRP.
Thyroid function too, you mentioned.
Yep. Thyroid function tests, TFTs. And if you're thinking autoimmune or inflammatory, you check for things like ANA, anti-nuclear antibodies, and other specific autoantibodies. Serum myoglobin can be checked too, alongside that urinalysis for myoglobinuria.
Can an ECG help at all?
It can sometimes offer clues. If there are electrolyte problems, like low potassium, hypokalemia, you might see ECG changes, prolonged PR interval, U waves, wide QRS, STG changes, plus some specific myopathies like Duchenne can sometimes have associated heart muscle involvement, which might show up on the ECG.
What about looking directly at the muscle biopsy?
Muscle biopsy is often really important, yeah. Taking a small sample of muscle tissue lets us look at it under the microscope for characteristic changes. It can be crucial for diagnosis.
But it's not always the final answer.
Not always definitive on its own, no. You have to interpret it alongside everything else, the clinical picture, the blood tests, etc.
And nerve studies, nerve conduction studies, EMG.
Right. Nerve conduction studies, NCS, are usually normal in a primary myopathy. And it's super helpful because it steers you away from nerve problems.
Rules out neuropathy, essentially.
Exactly. Electromyography, or EMG, looks at the electrical activity within the muscles. That often does show characteristic changes that confirm a myopathy is present, especially in those proximal leg muscles.
Is imaging used much, like MRI?
MRI can be useful. It can help rule out neurological mimics, like spinal cord problems. It can also show the pattern and extent of muscle involvement, maybe inflammation or fatty replacement of muscle, and look for complications.
And genetics. You said many are inherited.
Absolutely critical now, especially for the inherited types. Genetic testing can identify the specific gene defect. This confirms a diagnosis, helps with prognosis, is essential for genetic counseling for the family.
And potentially for future treatments.
Exactly. It opens the door for potential targeted therapies down the line. Clinical genetic testing is available for lots of these conditions now.
Okay, so let's say the diagnosis is confirmed. What's the management plan look like? What can be done?
Well, the main goals are always to ease the symptoms, improve strength and function as much as possible, maintain mobility, and really enhance the person's quality of life.
It sounds like a team effort.
Very much so. It's usually multidisciplinary. Physical therapy is absolutely key for strength, flexibility, preventing contractures.
Right.
Assistive devices, walkers, braces, wheelchairs later on if needed, and orthotics can make a huge difference to independence.
What about medications?
Meds depend on the cause. For inflammatory myopathies, immunosuppressants like steroids or other agents are the mainstay. For other types, meds might be more for symptom control pain, for instance. Lifestyle adjustments are often needed too.
And support?
Crucial. Genetic counseling, especially for inherited types, is vital for the patient and their family, and just general family support. The plan has to be tailored to the specific myopathy and how severe it is, and it needs regular review.
Are there emergencies in myopathy? Situations needing immediate action?
Yes, definitely. Acute presentations can happen. Severe respiratory weakness needing urgent support is one. Cardiac problems can occur sometimes. Acute metabolic crises and the metabolic myopathies need immediate treatment. Rhabdomyolysis, that rapid muscle breakdown, is a true medical emergency because of the kidney failure risk.
Right, protecting the kidneys.
And sometimes conditions like polymyalgia rheumatica, which causes muscle pain and stiffness, needs urgent steroids.
What about the long haul, long-term care?
Long-term care focuses on managing ongoing symptoms and preventing complications. Monitoring lung function is really important because respiratory muscle weakness is common.
So regular breathing tests?
Yes, pulmonary function tests. Chest physiotherapy can help clear secretions. Some people eventually need help with breathing, maybe non-invasive ventilation overnight, or even a tracheostomy and ventilator in severe cases. Ongoing medication management, continued genetic counseling for family planning, sometimes surgery like tendon releases to help with contractures, plus providing the right physical aids, ongoing support for the family, and dietary advice are all part of it.
Looking ahead, what's the prognosis generally like, and what are the main complications to watch out for?
Prognosis is just so variable. It really depends massively on the specific type of myopathy, the cause, when it started, how fast it's progressing. Some are fairly stable over many years, others are relentlessly progressive.
And the complications stem mainly from the weakness?
Mostly, yes. Mobility issues, obviously.
Right.
Respiratory failure from weak breathing muscles, and related to that, a higher risk of aspiration pneumonia.
Right.
Musculoskeletal problems, too, joints getting tight, contractures, sometimes spinal curvature or other deformities, and a few very specific genetic types. There's that risk of malignant hyperthermia, a dangerous reaction to certain anesthetics.
Is there any way to prevent myopathies?
For the acquired ones, managing underlying conditions or avoiding trigger medications or toxins can help. For the inherited ones, prevention is tougher. But genetic counseling is key.
Helping families understand the risks.
Exactly. For conditions like Duchenne, counseling explains the inheritance pattern. Carrier testing can identify female relatives who carry the gene without symptoms. Prenatal testing might be an option for some families with a known mutation.
And the future.
Well, the hope lies in molecular genetics. Understanding the defects opens up possibilities for future gene therapies or other targeted treatments. That's where a lot of research is focused.
Okay, let's try and summarize the key takeaways from this deep dive. Myopathies. They're a really diverse group. The core issue is muscle weakness and dysfunction coming from the muscle fibers themselves.
Right, and the causes are broad, genetic, inflammatory, metabolic, toxic, lots of possibilities.
Diagnosis relies on putting together the clinical picture, that often proximal symmetrical weakness, with investigations like CK levels, EMG, sometimes biopsy, and increasingly genetic tests.
Yeah, and management is all about support, physio, aids, managing symptoms, treating the underlying cause if possible, and anticipating complications like respiratory issues.
So a provocative thought to leave you with. We touched on genetic therapies, thinking about how rapidly that field is moving. How might those advancements truly revolutionize things for inherited myopathies in the coming years? What possibilities could open up that we can barely imagine now? Something to think about.
Definitely food for thought. The potential is huge.
Absolutely. And if you want to explore this topic or others further, especially if you're studying for exams like the MSRA, do check out passthemsra.com.
And there's also freemsra.com for more resources, both really valuable sites.
Well, thank you for joining us for this deep dive into the complex world of myopathies.
Yes, thanks for listening. We hope this breakdown was clear and helpful for your understanding.